fundus, body, neck, full of high strength. I am repeating internal echoes and surrounded by a small amount of fluid along its anterior wall, and this is the liver, this is the portal vein, this portion. In transverse section, the gallbladder measures, this is the gallbladder in transverse section. It measures 5.5 centimeters, and more than 5 is considered to be pathological or of significance. Now a gallbladder that is full of that measures more than 5 millimeter is full of high strength internal echoes, and the wall is not seen. Rather, in place of the wall, we see a hypoechoic rim around it merging into the adjacent liver. This is the portal vein. So this gallbladder is, you will report your finding as I have narrated, and do give a caution point that the possibility of any aggressive pathology cannot be ruled out, for which we need further investigation. Though its identification becomes easy when we see the calculi shadow posteriorly and the calculus at the fundal region, that what area we are seeing is gallbladder and not something else, some other region or some other organ, or not a bowel. Had it been a bowel, it should have changed its shape by now, and we should have seen movements in this area. There are no movements. I am scanning this patient for the third time in 3 hours, and the findings are persisting. So again you see small amount of fluid is seen. So this is a case of empyema of the gallbladder. Again, this is the gallbladder, and this is the portal vein. This area is the portal vein, and this is small amount of fluid. This is fluid. So distended gallbladder, number 1, full of different strength internal echoes. Number 2, with calculi in its fundal region. Number 3, with high density echoes giving sharp posterior shadows within the lumen. Number 4, with fluid in the surrounding the anterior wall, was number 5, and the GB wall is not seen separately. Rather, a hypoechoic rim is seen surrounding this distended gallbladder, which makes our differential bit difficult, as in this case we have to report that the possibility of any aggressive pathology cannot be ruled out. So you see, this is how we study the gallbladder pathology. Siddhe ho jao. Baji siddhe ho jao. We should always try to see the pancreas in all cases of gallbladder disease. You see now, this is the This is the pancreas, body of the pancreas in transverse section. As this is the splenic vein, its identifying landmark. This is the duodenal gas bowel shadow. This is the stomach bowel gas shadows, and anteriorly lies the microbe of the liver. So in transverse section there is no significant finding relating to the pancreas, and in longitudinal section this is the pancreas, and we don't see any pathology relating to the head of the